Great. Hi. Well, thanks very much for the invitation, and it's a real honor to be able to do this live case for CSI. I'm Suneil Aggarwal, one of the cardiologists in Liverpool. With me is my colleague, Dr. Nick Palmer, our fellow, Dr. Momia, and the rest of the cath lab staff. We have Rasheen, Andy, Anoop, and Dennis, and Audrey. So if we can perhaps first go to the presentation, and we'll just show you the case that we're doing.
Is that presentation on the screen?
So we go with the presentation, yeah?
Yeah, on the screen, perfect, sorry. Thanks for the introduction, Dr. Aggarwal. Thank you everyone for listening. So just a brief overview on the case that we've got for you today. We're planning on closing a patent for Monavale. The patient's a young man, presented with a CVA in January of 2023, so just this year, with odd symptoms of a sensation of loud music in his head and some dysarthria, which recovered fairly quickly, but an MRI confirmed a left cerebral infarct. Not much in the way of past medical history, variable frequency of migraines, but there was no specific cause found for his CVA. He's a non-smoker with a Holter that was negative for arrhythmia and only very mild plaque disease in his carotids. So this was his bubble contrast image at rest. Hopefully that's playing for you all. And then on Valsalva, you can see the whole, you can quite clearly see there's a lot of bubbles that transmit through.
Kind of
and so he went on to have...
You see the bubbles in the LV more than the LA, right? I mean...
I think that's probably the projection, but yes, I agree with you. You tend to see it more in the LV anyway. The cavity is larger, I suppose. And it isn't like there's a massive shunt of bubbles instantly through. So he went on to have a TOE. And it's probably the best picture of the flap that we could find. Following which, with some Dopplers, apologies for the speed of the flow on this. I couldn't quite get it to slow down for the presentation, but you can see that there's flow across the flap. So in terms of indications for closure, most guidelines all tend to say the same thing. So in young patients with the sort of ischemic stroke of undetermined cause, despite assessing for undetermined cause, so looking for AF and looking for atherosclerotic disease, it's reasonable to close PFOs with a transcatheter device. And that's across the board through most guidelines.
So we're actually also using the Cocoon PFO occluder, which I noticed that you used for the last case from SMT. I know you've had a bit of a discussion about it, so I'll just very briefly mention we've been using this device along with the SMT Cocoon ASD occluders for about the last year and a half or so here. It's, you know, a well-established device, has been used in South Asia for a long time. And it's a pretty standard double disc device, very similar to the Amplatzer device. I know you've already had the discussion about nickel allergy and the theoretical benefit you may get with the platinum coating. And I agree with what Horst said earlier. We have the odd patient who, although there's not really very good evidence that this helps, but some patients feel secure with this knowledge if they had a severe allergy. We had a patient of only a few months ago who insisted on this device for that reason. So yeah, it's just the standard device, but you have choices. Either you can have the two discs of different sizes, so the standard sort of 25mm device with an 18mm disc, and also there's you know, devices with two 18mm discs, two 25, two 30 discs, or a 25 and a 30. So you have all those. I think we'll just skip the slides about the nickel since we've had that discussion. So these are the different devices available. But I would say we use probably 90% of the time the 25mm device with the 18 on the left atrial disc seems to do the job. Yeah, so that's it. So I think if we perhaps now move forward onto the case.
Suneil, it's Radha from Bristol. Can I just ask if you do transesophageal, the TOE, do you do that on everybody before the procedure? or not? What does it
Yeah,
add?
so our practice is that we actually do these procedures under ice. So we feel a lot more secure by getting a TOE before, and then we're just more confident of the anatomy. Because, you know, occasionally if you don't do it, we find, oh, there's an ASD there that we weren't expecting, or some other issue. And, you know, is there a big atrial septal aneurysm? So my practice, certainly, and Nick, my colleague as well with me here, our practice is to get a TOE, then we're just much more confident when we get to the procedure about it.
Thanks.
Okay, so if we can perhaps switch over to the screens now and just show you the ICE catheter. So we've got our ICE catheter in. So you can quite well see, I think there, the PFO. It looks that it will open up when we cross it with a wire. We also add some color. If we could just put that back on, please. And I would say this is, you know, fairly standard PFO morphology. And I imagine most likely we'll be using the 25 device with the 18 on the left atrial side. I mean, what I have been doing is a bit like you were discussing earlier with the wire technique. If it opens much more with the wire, I might consider changing that. And very rarely balloon sizing in our practice here. So we'll probably just go ahead now and try and cross this and go from there. Meanwhile, if you want to have some discussion.
So while the septum prim is undulating a bit, it does not appear to have an excursion that meets atrial septal aneurysm criteria. Is that your thought?
No.
Yeah, that's what, right. So wire straight through. Yes, I'd agree with that. It doesn't seem to be sort of aneurysmal as such. So yeah, so the wire has gone straight across, really. So, and I have to say, my practice is, again, usually just to put the sheath in on a standard wire rather than a stiff wire, but make sure to dilate the groin properly so that it goes in fine.
So we just had a discussion on the stiff wire importance to estimate the size of the PFO. So do you do balloon sizing, or you just, you know, make...
No, we don't actually. We just use this. And I think if this opens it a lot, maybe. I have to say, you know, probably on a tug test I had, strangely enough, only last week, but for the first time in about 3 years, a device come back and then just upsized it to the 25. So I don't think there's huge necessarily merit in it, but I know it's you know, different people do different things, obviously.
I think if you have a very aneurysmal septum and you say you're at a widely open PFO, it might help with sizing, but even in that scenario, you know, you can easily upsize the device or change to the, you know, here we have a tendency to use the normal PFO most of the device most of the time, but we can upsize to the cribriform of different sizes and equal disc lengths. But I must say, I was listening to the previous case, and obviously there's a lot of measurements taken. I felt quite embarrassed. We don't do a lot of measurements of our PFOs in terms of tunnel length and etc. We try to keep everything as simple as possible. So balloon sizing is a rarity. Doing intricate measurements of the PFO we might do in advance with the TOE, but not during the actual procedure.
But here you're using ICE catheters. So would you like to highlight a little bit on your imaging strategy? We have also very variable audio quality from your site. So one of the mics perhaps is not turned up completely. If you want to change that, and perhaps explain a little bit. You're using two-dimensional ICE. Do you also use three-dimensional ICE, or when do you do TOE? When do you use ICE? Is ICE necessary in every patient? Is it because of comfort? Do you intubate your patients if you do TOE, or do you do conscious or no sedation with TOE?
Okay, so basically, the vast majority of what we do is ICE-guided PFO. We have a TOE assessment beforehand for all our patients. So essentially, the idea that the ICE is two-dimensional. We don't use 3D capability. And yeah, I mean, I started the program of local anesthesia and ice based on one, patient comfort, two, I think the imaging, if you have good imaging beforehand, you know, needing detailed imaging during the procedure is less important as long as you know the anatomy of your PFO and you know that there isn't any, you know, anomalous things, penetrations, large aneurysm that you're aware of. So we really do very simple 2D ICE imaging based upon, you know, a couple of views to visualize the PFO. In terms of intubation, so when is our indication to do a TOE on a patient? Well, I think, you know, I defer to Suneil for those types of cases because we feel they should involve cases that are on ACHD lists rather than my simple PFO list. But it's in cases where perhaps the anatomy is a little bit ambiguous, where there may be fenestrations, there's a bit more complexity, maybe lipomatous hypertrophy, and your device selection has to be a little bit different. But also patient comfort. You know, we know that over the years, putting patients under a general anaesthetic and doing TOE has its issues with recovery, with groin closure. And so we moved to this, I think, as many centres do, because it does encourage a more day case type approach. And for PFOs, which are simple to the vast majority, it's more than straightforward enough to do. So TOEs are really reserved for complexity, and patient choice is always an important factor, but not many patients really, you know, sort of balk at the idea of having just a bit of sedation and local anaesthesia to have an ICE-guided procedure. The final question is, the TOEs are carried out under GA, which is also a limitation at our centre these days. And so part of the movement towards local anaesthesia and ICE was based on GA provision within the labs as well, which is another factor. So we don't do conscious sedation for TOE here.
Okay, I'm just going to show a couple of things related to the Cocoon device. So there's actually two different delivery cables. There's a 5 French and a 6 French. The 5 is obviously slightly more flexible. It's not quite a Trevisio, but I'd say it's a bit more in that sort of direction. The 6 is a bit stiffer. The other thing about this device, and it's
Suneil,
a really
can you
minor...
enlarge your picture of the trolley?
Oh, yeah. Yep, sure. Could we
It's done.
see that now? So, yeah, that's the delivery cable. In terms of the device, you can see it comes mounted on this bit of card. I know it's a really minor point, but I have to say I'm less worried about dropping this than I was with the old Amplats. As I know, obviously, with the Talisman, it's all connected, but I do feel there is some merit in this. Yeah, I think once you're on, the card just makes it a bit easier to mount.
Could you magnify a little more?
Yeah, we can magnify that, hopefully, for you. Can you see that?
Yep.
Yeah, make it even bigger. That's right.
So yeah, so like I say, it just comes mounted on this piece of card, and I think it just makes it easier to get on. So we'll then take the card off. And as Horst mentioned, it's just very similar to an old Amplatzer device, really. So if Nick would just flush it through.
Mm-hmm.
I like the term very similar.
Yeah.
So, Stefan, I have a question. So, in Japan, we cannot use the 3D eyes.
Yeah,
so, but,
if we do one more.
When you do the PFO closure, is 3D eyes useful? Because the width is so narrow.
Actually, the width is narrow. It's okay. It's 90 by 60 degrees. Actually, a new development we just started a week ago is that we have the mini TOE probes. So there is a new probe from 2 vendors. The first that is CE mark in Europe is the GE mini TOE, and there's a second one coming from Philips also. And the size of these devices has shrunk the normal size of a TOE probe from approximately 16, 18 millimeters down to 11 now. So to compare it to an intravascular device, this would be a sheath of 32 French, which is a standard size for tricuspid valve implantation, which is 35. So it's smaller. The TOE probe now is smaller than the sheath you put in for a valve replacement transcatheter.
Can these mini TOEs go through the nose, transnasal?
You could, but there is no big advantage. Actually, we tested it now for the last days, and I did one case this morning, and actually the patients tolerate this very, very well. So the swallowing or any type of vomiting is further away. There is the problem that there is only one major disc to turn, so you can only flex and anti-flex, but there is no side control on these smaller devices. But it enables actually full 90 by 90 degrees. It has about 40% less matrix elements than the big one, of course, but it goes from 5 kilograms to adults, and you can use it in adults. 3D,
has 3D.
full 3D.
Yeah.
So you can use everything you know from the 6 megahertz or 8 megahertz probes, and these probes go up to 11 megahertz. So also your temporal resolution gets up, actually, so they're faster.
How about the visualization? Because small probe will be maybe floating in the edophagus.
Exactly. So the probe is more flexible. It's softer, actually. So it's also very nice if you have some varicosis of the esophagus or other situations. It is more flexible. You will have to make sure that you really align to the wall of the esophagus more than you do with a larger probe. That's the only thing. But the image quality is superb and exceeds by far the micro TOE probes that you use transnasally. And there's also a very good toleration under conscious or no sedation even. So we did 2 cases of no sedation this week.
If we could see the fluoroscopic, please, screen in addition to the eye screen. Thank you.
So can you see the 2 screens now?
We only see the ice. We don't see the fluoroscopy.
Okay. We'll get both of those up. 1 second. Let me know once you're seeing them.
No.
We do.
But the other one image is blurred now. Your table image is blurred. Now it's better, yeah. But we only see you from the back there.
Yes, sorry. That's just... So you can see the device here. Just...
From the technical standpoint, can you zoom in a little bit on the table camera? This was blurred before, but if you could perhaps zoom in a little bit to the table. Yeah, we see it, but it's not. It doesn't give us a sharp. It doesn't give us a sharp image.
So we can see where we are.
So I mean, the setup is really very similar to the Amplatzer, standard sheath loading system. And deployment, as you probably saw on fluoroscopy and ICE there. So I think if we're going to do some stability tests now, and then we'll put some color on.
But the cable seems very stiffer than the Trevisio.
It's definitely stiffer than the Trevisio, yeah. Like I say, they do have 2, a 6 and a 5 French. It's probably a little bit less stiff than the 6 French, but it's definitely stiffer than the Trevisio. It's more in keeping with the older Amplatzer device. So if I just show you some stability testing there.
If you retroflex your ICE catheter, sometimes that just gives you a little bit more space to see.
Yeah, we can do that for you.
This ICE catheter is quite interesting in that you do try to retroflex it, and then it.
It's the ViewFlex ICE catheter that we use is definitely not as manipulable as maybe some. Should we just put color on there, please?
Screen the ICE catheter.
So we seem to have tissue in on both ends. It seemed pretty stable on a push-pull test.
Can I ask you something, please?
Yeah, sure.
This is Dr. Amal from Egypt.
Hi.
I can see that you're not covering the whole aneurysm and the device is not that parallel to the septum. Aren't you worried that this device may be small, or would you do a bubble test again just to make sure there are no small fenestrations in this aneurysm?
I mean, that's a good question. I think the thing is we have had the TOE before and we tend to really rely on that for some of those finer details. I think, if we had doubts on the TOE about another defect, we definitely would do a bubble test. But I think in this particular case, we're pretty confident on the TOE that it's a single lesion. In terms of covering the aneurysm, I think it was mentioned in the last case as well that, there isn't really data that completely covering the aneurysm seems to reduce stroke risk. And I think probably in the long term, like Horst mentioned, having as small a device as can safely be put in is better, maybe less irritation, maybe lower risk of arrhythmia. I suppose it's not proven, but that would be my thinking, really.
So can you do a push on the cable in this view just to make sure the right atrial superior aspect does not prolapse into the
on
PFO?
the ice?
Yeah, the ice view is good, yes. So notice how, and you'll feel resistance, so you really have confidence this is properly sized.
Could you make the eyes bigger?
The ice bigger, yeah? Could we just make the echo, just single screen echo?
That's nicely shown actually at the moment.
Yeah,
when you
so
pulled
I
a
think
little
you can see
bit,
the pull, you
yeah.
can see the push.
Yeah, you see
Point
that
is made,
also. The left
very well
disc
about
is very stable.
Yeah.
Do you do fluoro with it if you do this, and what's your fluoro angle? What do you prefer in this situation? You're almost deployed. Do you go LAO? Do you go cranial? I saw only 2 degrees cranial here in your case.
So we tend to go LAO actually before we finish off, just to see the orientation, and I can just show you what it looks like there as well. But I think to me it looks pretty stable and in the right position. So I think I'm going to go and release it now.
I know. Can people hear me actually?
How's the financial coverage in the NHS for ICE catheters? How many allowances do you have per year?
Yeah.
Or do you get every procedure paid for the additional ICE catheter?
Yeah, so the way it works is really we can use it because, of course, the alternative before was anesthetic, and the cost of a general anesthetic was significant, and also there are contracts in place to sort of mitigate a little bit for the cost of the ICE catheter with maybe reduced costs of devices. So previously it was probably the limiting factor for ICE, but now it's definitely cost neutral compared to anesthetic. And compared to penalties of having very long waiting lists for these PFO patients, which we definitely used to have.
You factor in the day case element of this, it guarantees almost day case work, whereas TOE is less.
John?
Yeah, Megan? On that front.
We have a question from Megan.
This is Megan Coylwright. You brought up the question of 3D versus 2D ICE for PFO, and we got derailed on TE again. No, I'm just teasing. But I do over 250 ICE-guided cases a year, and so I do try the 3D in different settings, and I feel like the 3D gives us the same thing as you had said earlier. Our nose is on top of this device. Don't you all just want to lean back so that you can see a broader view? And I feel with the Flex View, it is very hard. The AccuNav 2D, you can lean back. But I found with 3D, you are right on top of the septum. And it does influence your ability for transeptal punctures for others because it's so different. So I think each of the ICE modalities has different degrees of flexibility. And for PFO closure, I think being able to lean back and look at all angles is really important if you're uncertain about insertion between the 2 discs.
Yeah, there are also possibilities, of course, to use jugular versus left femoral approaches for the venous access, which has actually also different distances to the object of therapy here, and there are many more possibilities. Of course, if you want to add some complexity or some payments, you can also use a steerable sheath, which gives you complete freedom. So you can move away from the fossa, and you can also, of course, rotate and move more anterior. This also brings you away from your puncture site. As we're turning to 4 or 5 o'clock in order to go there, actually moving anterior also pushes you back.
Mm-hmm. So we have a very nice
you've seen some of those images.
Yeah, it looks good now.
Just put some color on there. Yeah, you can see it's flattened down. Looks quite.
And now we have 2 centimeter distance to the ice probe.
Yes.
So what is your medication strategy in the upcoming months? Single
So-
antiplatelet, dual antiplatelet therapy, aspirin forever. What do you do?
Yes, so our patients are on clopidogrel mostly because that is the guidelines here for post-stroke. I tend to then add in 3 months of aspirin to cover that period of endothelialization, and then stop the aspirin and continue the clopidogrel long term. I mean, that sort of in conjunction with the stroke physicians, that is a sort of standard really. So that's what we do.
I want to talk a little bit more about mini TEE and adoption for general anesthesia. I mean, in the U.S., John, do you see us getting away from general anesthesia with TEE, even with the mini? Because we're talking about the mini TEE advantages and that patients need less sedation and no GE. In the U.S., I just don't see the mini TEE changing the fact that we're requiring general anesthesia.
So we do 0 general anesthesia.
Interesting.
I do 150 occluders. I do perhaps 2 to 5% ice, and the rest is, I would say, TOE with conscious sedation or no sedation. Actually, these procedures are 10 minutes to 20
No,
minutes.
I'm talking about if you want to use it mitral clip, for example. If you want to use the mini TEE for longer.
Well,
not
we're
for
testing this at the moment. Actually,
Yeah.
we're 98% conscious in TAVR, but we're still
Are you
general
going on?
anesthesia for mitral
It's all
and
gone
for
well.
tricuspid. But I see the advantage of ICE going into tricuspid, where the image quality is superior to all left-sided procedures. So LAA, I'm not so convinced, in mitral, I think ICE there is not yet competitive. But I see TOE and mini TOE as possible alternatives, actually. And we will, I think, over the next 2 years, move away more and more from general anesthesia in valvular heart disease. Not only in TAVR, but I anticipate this also for mitral and tricuspid.
So patients really tolerate the TE for how long, the mini, without general? Hours, you think, or 15 minutes?
Well, the procedures don't take hours. If you look into the latest EXPAND data, the device time, so after you bring your sheath over, is only 30 minutes now. It's a 30-minute procedure, not longer, on mean, of course. Experienced centers have much shorter times. My least time was 7 minutes for a mitral procedure. So then you can also do conscious. I've done 10 conscious cases. I'm not happy with every one of those, so it's a transition period. But I would not say, and if I asked my anesthesiologist 8 years ago, he would say general anesthesia forever for TAVR, and now it's 2% only. So if there's a language barrier, if you cannot communicate to the patients, we still go GA. But 98% of all TAVRs are conscious.
Yeah, for TAVR is not a problem. I'm talking about TEE really requiring anesthesia.
But having done 150 occluders per year conscious with TOE, and this is between 10 minutes and 30 minutes, it can be done. You don't take the most complex cases before, I would say, and if you go to the easier 20%, you can start with that. I'm not advocating to go away from general anesthesia in all mitral and tricuspid cases, but I think there will be a transition.
So you're finishing up and you have a nice result. Do you use closure devices on your venous access? Do you send patients home the same day, or a week later, like in Germany, or what?
Yeah, we tend to
John,
figure of eight.
we discuss on this later.
Get away with that.
Yeah, well, we put a figure of 8 suture in the groin. We usually keep patients lying flat for 3 to 4 hours and then remove it. We'll go and do a bedside echo later this afternoon to check everything's fine. And then our patients usually are discharged home the same day. So I think once at sort of 4 to 6 hours post-procedure. So we tend to do them in the morning, 2 or 3 cases usually back to back, so we can then echo in the afternoon and get them all home the same day.
Well, very nice case. Any final questions, comments from anyone?
Yeah, I guess now you have...
Yep, thank you.
Thank you.
Thank you. Thanks very much.
If we have more time, we have a little bit more time. So you have, Horace does it fluoroscopy. I mean, no echo at all. We have ICE. We have TEE. I guess if you can do it with least expense and least invasiveness, there's a good argument. So do you think TEE or ICE, right? I mean, so fluoroscopy, I guess a lot of us will maybe not do it on a fluoroscopy. Would you think ICE or TEE going to take over with PFO ASD closure going forward?
I think it depends on the reimbursement system of the country. That's the main thing, and it also depends on how well your patients tolerate actually a TOE without any sedation or with conscious sedation. So this is different in Europe. So the more you go to the south of Europe, the more you will see general anesthesia. In the north or in the central of Europe, so some parts of France and Germany and the Scandics, etc., patients tolerate actually TOEs very well. So for diagnostic and therapeutic options in Germany, I think the majority of centers does no general anesthesia, the majority. And also we're allowed, unlike other countries, to use propofol actually. So we use a 50% dose of propofol, which is less than for full intubation. And under this, you can do procedures very well. And it's allowed for cardiologists in Germany. It's not allowed in every country in Europe. So in some countries, you have to have an anesthesiologist for that in order to use the substance, like in the US, etc. So there are differences, and they will change the situation. Generally, you earn more. You lose, of course. In Germany, you're not being paid for your ICE probe. So you lose 2,500 to 3,000 euros per procedure. When you do 150 procedures and you add 3,000 to it, this is an amount of money, of course, that you lose for your hospital.
How about in Japan?
Oh yes, I think actually we don't care about the money like
That's
that
good.
because we have a national insurance system.
I
so,
can come to Japan.
Yeah, some doctor would like to use both TE and ICE catheter simultaneously. So
In terms of results using both either TE or ICE, is there any evidence for better results on one of them, or the clinical
No.
results should be the same?
There's-
What about patient experience? I mean, has anybody looked into that? I mean, in terms of patient experience in unanesthetized with
Yeah.
need for TE?
I think there are some registries out on the ICUs now, and there will be in the future also randomized trials on ICE versus TOE. This is upcoming, especially with 3D ICE, in order to show benefits, comfort, but also outcome situations, etc. I think there will not be huge difference. It depends really on the center experience. This is far more important. I see ICE more on right-sided procedures, to be honest. I wouldn't cross with an ICE catheter necessarily to the left atrium in all cases, or to do a mitral clip and enlarge the septal defect even more. I'm personally, if I'm on the left side, I would go for TOE predominantly. If I'm on the right side, I'm open for ICE, I must say. And I think there is the best perspective on ICE in the future.
Yeah. I think the good thing that everybody gets for a set of propofol, they're going to forget what they've been through. I mean, so really, right? Post-procedure, a lot of patients may not remember what happened during the procedure. So hard to say about the experience.
Give some
for
benzos.
For ICE, though, they recover very quick. For ICE for a PFO, they recover very quickly. And I think the lab turnaround time is quicker for us with ICE than it is with a general anesthetic. So you can do more patients.
Absolutely, I agree on this. If you need general anesthesia, then go for ICE. If you don't need general anesthesia, stay with TOE and you save a lot of money.
All right. Thank you, everyone.
Thank you.
Thank you.
Thank you.